Good morning, everyone. Topic for today's seminar is General Principles and Rationale of Radiation Therapy in Pediatric Solid Tumors and Side Effects of the Radiotherapy. The objectives which will be covered include biological basis of radiotherapy, physical basis of radiotherapy, modes of delivering it and technical basis of radiotherapy along with various techniques, role of radiotherapy in solid tumors and the side effects of the radiotherapy. Radiation oncology is the branch which deals with the radiotherapy and it provides a biological effect while treating the cancers or the other benign condition. The goal of radiotherapy is to deliver the prescribed radiation dose to an identified target volume and relatively sparing the normal tissue, which is adjacent to the tumor. Radiations, what are radiations? These basically implies the emission and propagation of energy through space or the material medium. These can be of two types, electromagnetic radiations and the particulate radiations. Electromagnetic radiations like X-rays and gamma rays. X-rays are produced when they are emitted when high velocity electrons hit high atomic number substance such as tungsten and molybdenum. And gamma rays are emitted when there is intranuclear disintegration. Particulate radiations are produced by the particles which have definite mass, momentum, and position in this space, such as electrons, protons, and the neutrons. Coming to the clinical consideration, radiotherapy is used for the management of cancers, and multidisciplinary approach is used while we are dealing with the cancer, such as surgery, chemotherapy, radiation therapy, and the immunization therapy, molecular biological molecules. These aim to combine these therapies to achieve maximum tumor control while minimizing the long-term side effects. Radiotherapy in this scenario can be used preoperatively, intraoperatively, and postoperatively, and sometimes it can be used without surgical intervention as well. Coming to the biological basis of radiation therapy, how the radiations affect the tumor cells basically. So when the ionizing radiations interact with the intracellular components, they do so within 10⁻⁻12 seconds of their exposure. So they causes the DNA damage of the tumor cells. Now this DNA damage can be caused by the direct effects on the DNA or by the indirect effects on the DNA. Indirect effects is mediated by the ionization of the water molecules, which produces the free radicals that causes DNA damage. Now, this DNA damage is dose dependent. It can be lethal or it can be sublethal. Lethal damage occurs when there is accumulation of the double strand breaks. That is a type of the DNA damage which occurs. And sublethal damage occurs when there are limited double strand breaks or there occurs a single strand breaks, crosslinks, or the base damage of the DNA. Now, in a normal cell, there are certain induced cellular mechanisms for the DNA repair whenever any damage occurs. It includes nucleotide excision repair, base excision repair, homologous recombination, non-homologous joining, mismatch repair, etc. So normal cells, when they are damaged, they repair with the high fidelity. But in the tumor cells, DNA surveillance and repair pathway is often compromised during the formation of the malignant transformation, and they ultimately go into apoptosis. Success of radiotherapy depends upon the radiosensitivity of the tissue as well as the normal tissue tolerance of the surrounding tissue. So we have the two terminologies, that is the tumor lethal dose, which is defined as the dose required to eradicate the tumor cells in vivo. And we define a therapeutic index, which is the ratio of normal tissue tolerance to the tumor lethal dose. As per the therapeutic index, we divide the tumors as radiosensitive tumors, radioresistant tumors. The tumors which are highly radiosensitive, they have very high therapeutic index. That is, they have high normal tissue tolerance with a very low tumor lethal dose. The examples include seminoma and lymphoma. Moderately radiosensitive tumors have nearly high normal tissue tolerance, which exceeds slightly with the tumor lethal dose, and the TI is low, but still they are sensitive. This includes the squamous cell carcinomas and adenocarcinomas. Now comes the radio-resistant tumors, in which the tumor lethal dose is very high and normal tissue tolerance is very low, so that the therapeutic index is also very low, and the tumor does not respond to the radiation therapy. These include sarcomas, melanomas. Now coming to the fractionated radiotherapy. When the radiation therapy started as a management of the carcinoma, a single large fraction was used to be given to the tumors. and this produces the tumor damage. Also, the surrounding structures were used to be affected by the tumor, so the side effects were more. Now, with the time period we are advancing with the radiotherapy, the term fractionated radiotherapy has come. It means that delivering the total dose of radiation in divided fractions over a span of few days. The rationale behind is that while we are giving the radiotherapy in the fraction, it causes damage to the surrounding tissue. So the repair of the sublethal damage which is occurring into the surrounding normal tissue, that can be repaired within 4 to 5 hours, and then again next cycle of the chemotherapy can be given. So this is the basic effect of the fractionated radiotherapy. In most of the pediatric tumor settings, conventional fractionated radiotherapy is the standard, with a common total dose of 10.5 grade to 60 grade, and it is determined by the tumor type and its presentation. It is usually delivered in 5 daily fractions per week, and 1.5 to 2 gray are delivered per fraction. Now coming to the physical basis of radiation therapy. The physical goal of radiation therapy is to deliver a high dose to all the parts of the tumor while minimizing the dose to the surrounding normal tissue. Advances in the radiation therapy provides sophisticated means of conforming a high-dose radiation volume to the defined tumor target and increasingly sparing the critical normal tissue. So the basic aim of the radiotherapy is the same only. As we are advancing with the newer technologies and the newer advancement, the main focus is to target only the tumor, irradiate the tumor, and not the surrounding tissue, so that we can minimize the side effects. Now coming to the modes of delivery. Radiotherapy can be delivered via 2 forms. One is the external and another is the internal. External is basically the external beam radiation, where the ionizing radiations are delivered to the cancerous volume in the body from a distance via a machine. The machine will generate the ionizing particles, following which they are delivered to the body. Brachytherapy or the internal radiation is a mode of delivery in which the radiation source is placed within the organ of the patient and where the tumor is ionized or irradiated. The types of brachytherapy again can be based on the location of the implants. These can be intracavitary, interstitial, and the surface modes. Intracavitary can be used in the carcinomas such as cervix and esophageal. Interstitial brachytherapy techniques can be used for prostate and tongue carcinomas. And surface modes can be kept on the scalp, skin palate for the respective cancers. Now coming to the technical basis of radiation therapy. Whenever a patient is planned for the radiation therapy, there is a treatment planning system or radiation planning system which follow a certain rules and a certain scenarios following which the radiation is planned, in which again the multiple techniques are used and the radiation is planned accordingly. First of all, a CT simulation is done and the patient is positioned ideally for the treatment delivery. At this stage, appropriate molds and the cast are forms which allow the patient to be comfortably positioned for the therapy, and they ensure the daily reproducibility of the setup and maximum immobilization during the treatment. After this, a planning CT is obtained and additional cross-sectional imaging such as MRI, PET-CT can be obtained at this setup to identify the target volume. Then a target volume for the volumes of the tumor or the volume of the tissue which has to be irradiated is identified, and the most important point also is the identification of the critical normal tissue which will get irradiated and which we have to save from the side effects. Now, while we are considering for the target volume, the important terms which are defined include the gross tumor volume, the clinical target volume, and the planning target volume. What is gross tumor volume? It is the original tumor volume, which is defined on initial CT or MRI scan, or the post-operative tumor bed, when the patient comes and directly went into the surgery, and after that a tumor bed which has to be irradiated, it is considered to be the gross tumor volume. Coming to the clinical target volume, it is the gross tumor volume plus the subclinical disease. That is the oncologist which they have in the mind that there can be the area of microscopic extension by the direct infiltration of the tumor or the regional draining lymph nodes. So this clinical target volume is defined by the GTV plus the infiltrating margins which are positive, and it is bounded by the anatomical boundaries also of that space. Coming to the planning target volume, it is the geometric expansion of the clinical target volume that is exceeds by 3 to 10 mm. This basically includes the variation which can occur in the daily setup of the patient or any potential movement which can occur during the therapy. So while we are giving the radiation therapy, we mark all these target volumes, and radiation is given as per the planning target volume. Now coming to the different kinds of radiotherapy treatment techniques, we are proceeding with the traditional radiation therapy to focal radiation therapy, conformal radiation therapy, intensity modulated radiation therapy, proton beam radiation therapy, and the brachytherapy. The traditional radiation beam therapy is basically a most traditional method, and it is delivered by a photon beam that was generated by the linear accelerator. It is basically based on the non-volumetric imaging studies. Here, the total tumor volume is not defined, that how much volume we are irradiating with the radiation. Patients are positioned in such orientation that the radiation beam follow the conventional direction, such as they can go with anterior, posterior, or lateral only. The limitations of traditional radiation therapy was there was inability to convey the accurate location of the tumor bearing tissue, and the amount of radiation which was delivered to the tissue was also not proven properly. So we proceeded with the focal radiation therapy. Here, the techniques involved which provided a radiation to a defined volume of the tissue, and it was done with the help of CT or MRI scan along with the 3D construction. Here, relatively the lower doses were delivered to the adjacent normal tissue. There is certain criteria which has to be met to provide a focal radiation therapy, that includes the 3D data from CT or MRI, which is acquired when the patient is planned in the treatment position. This imaging data was used to delineate and reconstruct the tumor volume and the normal tissue in 3 dimensions. Then radiation beams can be freely oriented in the 3 dimensions for planning and delivery. And the distribution of radiation dose received by the tumor volume and the adjacent normal tissue is also computed. Another advanced form of the focal radiation therapy is the conformal radiation therapy. This is the same as the previous one, with an advantage of it uses a multiple fields or portals with each beam aperture shaped to the tumor volume. The beam modifiers are used to conform the radiation beam to the tumor, and it ensures that the tumor receives a homogeneous dose. Conformal radiation is specifically used when the tumor surface is convex with no other crucial structure invaginating the tumor area. It delivers the high doses of radiation while keeping the toxicity low to the surrounding tissue. Now, the next modality is the intensity modulated radiation therapy. This modality also uses the 3D reconstruction to delineate the target volumes and the normal tissue. Here also, the radiation is delivered to the target as multiple small fields that don't encompass the entire target volume, but they collectively deliver a prescribed daily dose. So basically, the target volume is divided into multiple fractions, and the multiple beams are transited to a particular fraction. So entirely they cover the whole total volume. It differs from the conformal radiotherapy in these aspects, including the increased complexity and time which is required for planning and delivery of radiotherapy, increasing the amount of quality assurance work which is required, increases the heterogeneity within the target volume. The intralesional area receives higher dose, or intensity modification can also be done. Suppose if your tumor volume is there, some part of the tumor will be highly reactive, some part of the tumor will be less reactive. So one of the part requires higher dose, another part requires a lower dose of the radiation that can be modulated with this therapy. It can be used to treat concave areas while sparing the crucial structure that enter the target area. It provides better protection of normal tissue with reduction of late toxic effects. Now coming to the proton beam radiation therapy. Here the radiation is given by the heavily charged particles. The strong benefit is that there is a capacity to end the radiation beam at a specific and controllable depth. After when the particle passes through the tumor tissue at certain depth, the energy of the radiating particle diminishes. So the after effects can be avoided by this. It protects the normal tissue which is adjacent to the tumor tissue but it has a limited use as it causes high expense in its construction and lower demand. Brachytherapy, as we have already read, that the radiation source is placed inside the body cavity and which provides the radiation. It is usually used in pediatric patients, specifically in the soft tissue sarcomas like RMS. Planning of the dose to be delivered to the target volume is accomplished after the resection. Strength of the radioactive source is determined prospectively, like how much amount of the radiation which will be delivered to the patient is defined is defined prospectively. Commonly used sources which are used for brachytherapy include iridium 192 and iodine 125. There can be of two methods of delivering RT based on the rate of radiation delivered. It can be low dose rate treatment or it can be high dose rate treatment. In low dose rate treatment, 40 to 80 centigrade per hour radiation is delivered, and it is delivered during a period of days where the patient remains hospitalized. In high dose rate treatment, 60 to 100 centigrade per minute is provided, and fractions of RT are delivered on several days during 1 to 2 week period. Now coming to the palliative radiation therapy, it's a valid intervention for patients who develop recurrence despite successful treatment of primary malignancy. Ultimate goal is to maintain the quality of life by minimizing the symptoms and number of disruptive interventions. Symptoms resulting from bone involvement or compression of the vital structures can be treated well, and it is basically an individualized therapy, depends upon person to person. Now coming to the interaction of radiation with the chemotherapy. As the management of the cancer is the multimodal and multidisciplinary approach is used, the combination of radiation therapy with systemic chemotherapy is done in a variety of tumors such as Wilms tumor, neuroblastoma, soft tissue sarcoma. When chemotherapy is combined with the radiotherapy, there can be three types of interactions which can occur. First, it can lead to the enhancement of the local irradiation. Second, there can be limited or a no sensitizing effect, or there can be increased radiation toxicity. There are certain drugs which, when used at the time of radiation, they cause an enhancement of the radio sensitization. This includes cisplatin, 5-fluorouracil, mitomycin, or gemcitabine. Sometimes the drugs are used at different points in a schedule, and the doses are modified as per the radiotherapy schedule. Now, there are certain drugs which causes limited and no sensitizing effect while giving along with the radiation. These includes ifosfamide or etoposide or vincristine or cyclophosphamide. Another drugs which can cause increased radiation toxicity by increasing the local tissue toxication, that includes doxorubicin, actinomycin. These both increases the toxicity in the mucosa and the skin. Another example include the irinotecan and topotecan. These also increases the toxicity. So these drugs should be withheld for 2 to 6 weeks after completion of the radiotherapy. Now coming to the recommendations of radiotherapy in various solid tumors which are used in our setup. First is the recommendation of radiotherapy in Wilms tumor. In Wilms tumor, radiotherapy is given for all the stage 3 tumors, where radiotherapy is to be started within 9 to 14 days of surgery unless medically contraindicated. Radiotherapy is given to the flank except where whole abdomen radiation is indicated, which includes a diffuse tumor spillage. Second, a preoperative or intraoperative spillage is there. Any intraperitoneal tumor rupture is there, or if there any peritoneal tumor seedling is there, or hemorrhagic or cytology is positive for ascites. Ascites is positive for malignant cytology. If a gross residual disease is present after surgery, then additional radiotherapy booster dose of 10.8 gray is delivered. At the time of giving radiotherapy, whole vertebral body to be included in the irradiated volume. For whole abdomen radiations, bilateral femoral heads and acetabulum should be shielded. If both whole lung radiation and abdominal RT is required, then it should be included both in the one field. Whole lung irradiation is indicated for all the patients with pulmonary lesions. And whole liver RT is also indicated for the patients with liver metastasis if the metastatic lesions are not completely resected. This is the table which is showing the different RT doses which are used in the management of the Wilms tumor with the stage 1, stage 2, with recurrent abdominal disease and the lung meds, liver meds. Different dose schedules are defined as per the COG and the SIOPL guidelines. This is the COG guidelines which define the different dosing which has to be given after a certain kind of tumor. Now coming to the role of radiotherapy in the neuroblastoma. In neuroblastoma, low risk and intermediate neuroblastoma, there is a minimal role of the radiotherapy, usually normally not used, but used in the palliative care later on. In a high risk neuroblastoma, radiotherapy is administered during the consolidation phase after the allogeneic stem cell transplantation, but it should be given before this therapy with this 13-cis retinoic acid. In the SIOPL protocol, radiotherapy is administered to the initial tumor site irrespective of the extent and the result of the surgery. SIOP and PUDC recommends the administration of 21.6 gray radiation to the primary tumor bed and to the residual bone metastasis, which are fewer than the 6th site. In other words, while the primary site is always irradiated in high-risk neuroblastoma, radiation is also to be given to the metastatic sites, which persist even after the chemotherapy or the other management. That is, that there is positive MIBG, or if the MIBG is not available, then FDG PET avid lesions are present in the body, which are demonstrated at the time of evaluation prior to the stem cell transplantation. Radiotherapy is typically administered 60 days after the busulfan to avoid the risk of busulfan-enhanced radiotoxicity. And 13-cis retinoic acid is also not co-administered with radiotherapy, as there is negative interaction which is associated with both of them. Coming to the palliative therapy, pain due to the bone or visceral metastasis is relieved with the external beam radiation therapy, and rapidly enlarging masses which are often non-responding to the surrounding to the other management can also be managed with the radiotherapy. Now coming to the role of radiotherapy in rhabdomyosarcomas. All the children of RMS require multimodality therapy. Systemic chemotherapy is administered for all of the patients in conjunction with the local therapy. Local therapy can include surgery and radiotherapy or the both. RT is recommended for clinically and radiologically suspicious lymph nodes unless the nodes are biopsied and shown to be free of the tumor. Techniques like three-dimensional conformal radiation therapy and intensity modulated radiation therapy are used to deliver an optimal dose to the tumor while sparing the surrounding normal tissues. Interstitial or intracapillary brachytherapy can be used whenever expertise are available. Chemotherapy should be modified to avoid the radiosensitizing agents such as dactynomycin and doxorubicin, which are used in the management of RMS. Now coming to the Ewing sarcoma. In the Ewing sarcoma, the main management is the tumor resection when margin and wide resection seems to be possible. RT is another reasonable option which is available alternative to the surgery. For the exclusive RT, for the gross disease, standard treatment includes the dosing of 55.8 to 59.4 gray, and it can be given in fractions with 1.8 gray per day. Dose usually recommended are 45 to 50 gray. Less than 40 gray doses are not enough for local control. Almost require dosing which is more than 40 gray. All these patients with poor histological response and have positive margins after surgery should receive radiotherapy. After good response to the chemotherapy, adjuvant radiotherapy can also be given, as adjuvant chemotherapy has resulted into the improved outcomes. What are the exceptions for radiotherapy? When the wide local excision is done with a negative 1 mm margin, more than 1 mm margin, and there is a good histological response with the pre-operative chemotherapy. At this scenario, radiotherapy can be avoided. It can be avoided in post-operative cases also, where the complications are outweighed by the benefits. Now, neoadjuvant radiotherapy can also be given for the patients who are poor responders to the chemotherapy. That is, there is less than 50% reduction in the tumor volume after the 2 cycles of chemotherapy. The neoadjuvant radiotherapy dose includes 36 to 63 gray, and usual dose is 50 gray, which can be given again in the fractions. It can be reduced to 45 gray if the patient is not tolerating well the radiotherapy. Now, coming to the role of radiotherapy in malignant GCT, as per routine guidelines, there is no such advised role of radiotherapy in most of the malignant GCT. The GCTs where the radiotherapy has the potential role includes the CNS germinomas, seminomas, and the ovarian dysgerminomas, and the recurrent germ cell tumors, which are unresectable following the salvage chemotherapy, can also be treated by radiotherapy. Now, we'll be coming to the side effects of the chemotherapy, radiotherapy. Sorry.
Good morning, everyone. Now we are going to discuss about the side effects of the radiotherapy. There is greater potential for growth in pediatric tissue that mirrors many side effects of radiation in this age group. We can classify the adverse effects into 3 groups. Acute, that occurs within the 2 weeks of radiation therapy. Then second is subacute, that occurs between 2 weeks to 3 months after radiation therapy. And the third is chronic, that is typically seen after 6 or more months after radiation therapy. Now, what is the mechanism of cell injury? Sequence of events caused by autocrine, paracrine, and endocrine messages that occur immediately after cell injury that will lead to variety of growth and inhibitory factors are going to be released that will lead to cytoplasmic, nuclear, and interstitial events that will further lead to cell death, production of ROS, reactive oxygen species, and alteration in gene expression, along with expression of pro-inflammatory and pro-fibrotic cytokines are seen. Now, what are acute side effects? Acute side effects are very common, but they are rarely serious and self-limiting. They occur in organ with rapid self-renewal, skin or mucosal surfaces due to radiation-induced cell death. They get resolved within 2 weeks of treatment completion. Occasionally, if they are severe, they can lead to consequential late effects. They are usually not related to cell death. Nausea that occurs within the within hours of first treatment can be seen due to radiation to the stomach or brain irradiation, or if we have given large volume of irradiation to any site. Origin of these abscopal effects of radiation are due to release of cytokines. Now, lymphopenia during radiotherapy. Radiation mainly kills lymphocytes in all phases of cell cycle by apoptosis. Lymphocyte count decreases within days of initiating treatment. However, granulocytes are relatively unaffected. Therefore, radiotherapy alone does not put the patient at the risk of infection. Now, subacute side effects. For example, radiation pneumonitis, radiation-induced liver disease. They are initiated subclinically during the course of radiation by cascade of cytokines. They are proportional to the mean dose delivered. Hence, 3D tools to calculate dose volume histograms used to determine maximum safe treatment. Combination of physical dose delivery measured by dose volume histograms, functional imaging of tissue damage, and detection of biomarkers of toxicity to individualize therapy. Now, the third is late side effects, include organ dysfunction, subsequent benign and malignant neoplasm, and adverse psychological sequel. There are two theories two theories that can explain the late side effects are direct damage to the parenchyma and damage to the microvasculature. Now, intrinsic radiation sensitivity and vulnerability to radiation-induced tissue damage is related to cellular activity and level of maturity. Recognizing the mechanism of organ growth allows better identification of relative radiosensitivity. This graph is showing the growth curves of different tissues with the age as the age progresses, how the reproductive and brain along with lymphoid grows. This table is showing the relative rate of development of different organs and at different level of age groups. Now, tolerance dose 5 by 5 means average dose that results in 5% complication risk within 5 years. And tolerance dose 50 by 5 means average dose that results in 50% complication risk within 5 years. Now, this table is showing that the range of TD5 and TD50 for different target cells and what is the complication endpoint of different organs. Now, late effects by organ system. First of all, we discuss about central nervous system. In central nervous system, late effects develop rapidly in first 3 years of life. Radiation insult includes demyelinating lesion with focal or diffuse areas of white matter necrosis. Mechanism of injury can be explained by first is vascular, that are centers for endothelial cells. Second is clonogenic death of glial cells, that is oligodendrocytes. And third is via the allergic mechanism, reaction of ionizing irradiation with oligodendromyelin complex produces antigen. Now we can see first late effect is neurocognitive deficit that can present by difficulty in reading, language, memory, and IQ. We can screen that by neurocognitive testing, and it can be managed by psychoeducation assistance. Next can be the vision loss that can be present as progressive vision loss, which we can check by visual evoked response, and that can be helped by visual aids. Leukoencephalopathy can present as seizures, neurological impairment that can be screened by MRI and CT scan, and we usually give symptomatic management for these patients. Then next is focal necrosis that can be presented as headache and mass effects, which can be screened by MRI, CT scan, PET, SPECT scan, which for the focal necrosis, we usually give steroids and we consider debulking of the necrotic tissue. Next is ototoxicity. That is basically presented as hearing loss. We usually check it by pure tone audiometry, and we use hearing aids for these patients. Next is myelitis. Myelitis can present as paresis, loss of sphincter control, can be checked by MRI, and usually prefers steroids and physical therapy for them. Different radiation doses have been shown, which are going to cause these late effects. Now, next is neuroendocrine. Neuroendocrine, the late effects of neuroendocrine we can see like growth hormone deficiency, which we usually present as falling off. We can see the falling off of growth curve. So we have to check the growth curve, pulsatile growth hormone analysis, and insulin stimulation test for the same. And we usually give growth hormone in these patients. Adrenocortic hormone deficiency usually present as muscular weakness and hypotension. We check cortisol level, and accordingly we give steroid supplements. Precocious puberty can present as early growth spurt and premature sexual maturation. For them, we check bone age, hormone assessment, and pelvic ultrasound we need to check. For hyperprolactinemia, these patients present with galactorrhea and menstrual irregularities. We can check the prolactin level directly, and accordingly we give the dopamine agonist to these patients. Metabolic syndrome usually presents like obesity, hyperinsulinemia. For these patients, we check fasting lipid, glucose, insulin level, and accordingly we have to manage the patient according to the deficiency. Like if glucose levels are like if there is hyperinsulinemia, so we have to manage the insulin level accordingly. Then we have next, that is thyroidopin releasing hormone, usually present as hypothyroidism. We need to check TFT, and accordingly we give the hormone replacement to the patient. Now we come to thyroid. Late effects in thyroid can present as overt or compensated hypothyroidism, hyperthyroidism, or thyroid nodules. Two of them present like hypothyroidism, that is thyroid nodules, and overt and compensated hypothyroidism. For these, we check free T4 TSH, and accordingly, in overt and compensated hypothyroidism, we give thyroxine replacement. While in thyroid nodules, we do ultrasound, and accordingly we send the sample for biopsy and manage accordingly. For hypothyroidism, we need to check free T4 TSH, and accordingly we give propylthiouracil and propranolol to the patient. Next are the musculoskeletal side effects. Musculoskeletal side effects include muscular hypoplasia, which present as asymmetry of muscle mass, reduced range of motion. We can manage them by physiotherapy. Second is spinal abnormalities, which include scoliosis, kyphosis, lordosis, decreased sitting height. For these, we need to check the spinal curvature, if there is back pain or not, if there is any gait abnormality present or not. Accordingly, we refer them to the orthopedist, and particular disease are managed according to the, like for scoliosis, kyphosis, we do surgeries accordingly. For length we can use braced and different techniques can be used. For length discrepancies, like limb and gait abnormalities, we can consider limb shortening procedures. For pathological fracture, we usually check it in radiograph, and accordingly we have to do surgical repair and immobilization of the patient. Osteonecrosis can be seen on radiograph and CT scan, and accordingly we have to give symptomatic and joint replacement. Slipped capitofemoral epiphysis can again checked on radiograph, and we need to get the surgical management done for these patients. Next is cardiac effects. Cardiac effects include cardiomyopathy, which present as fatigue, dyspnea, edema, and hypertension, and cardiomegaly. We can do ECGs, echoes, and chest X-ray for the same, and consider using diuretics, digoxin, and cardiac replacement. For pericardial damage, we have to do pericardial stripping, and these patients usually present with fatigue, dyspnea, friction rub, muffled heart sounds. Next is coronary artery disease that present as chest pain, diaphoresis, arrhythmia. We can check it on ECG, and accordingly we have to give cardiac medications and diuretics. Valvular damage can be treated by valvular replacement. And conduction abnormalities, for conduction abnormalities, we first check it by ECG and Holter monitoring, and accordingly we give antiarrhythmic medications. Now, pulmonary late effects include pulmonary fibrosis. These patients usually present with cough, fatigue, dyspnea, orthopnea, and cyanosis. Screening and diagnostic tests include chest X-ray, oxygen saturation, and pulmonary function tests. The patient need to avoid smoking and infection, and we have to refer these patients to pulmonologist for further management. Now, coming to the ovary, radiation causes decrease in the number of small follicles, impaired follicular maturation, and decreased estrogen secretion, along with cortical fibrosis, atrophy, and generalized hypoplasia, along with hyalinization of the capsule. Effect of RT depends on dose and fraction of radiation, age, and sexual stage. As we can see in the table, like meaning at 0.6 gray, there is no deleterious effect. But at 1.5, young woman is not showing any effect, but at the women's more than 40 years shows some risk of sterilization. As the dose increases to 2.5 to 5, we can see there is 60% sterilization in 15 to 40 years of age group and 100% sterilization in more than 40 years. With 5 to 8 grade, we can see the percentage of sterilization increase in young women, that is up to 70%. And at more than 8 grade, we can see 100% sterilization permanently in all the age groups. Now, ovarian failure. Ovarian failure means delayed, arrested, absent pubertal development, irregular menstruation, estrogen deficiency, presenting as hot flashes, vaginal dryness, dyspareunia, and infertility. We can do Tanner's staging in these patients to assess the ovarian maturity and LH, FSH, and estradiol levels. Accordingly, we have to give hormone replacement. Now we come to testes. Prepubertal testes are more sensitive to radiation. There are different effects on spermatogenesis. Different dose of radiation have different effect on spermatogenesis and Leydig cell function. For example, at 0.1 gray, there is less than 0.1, there is no effect on spermatogenesis and Leydig cell function. While from 0.1 to 0.3, we can see the effect on spermatogenesis is started, and while effect on Leydig cell function is started at 0.1 to 1 gray of radiation. Accordingly, as we proceed, as the radiation dose is increased, it can lead to azoospermia and reduced testicular volume. And for Leydig cell function, it can lead to permanent increase in FSH and no change in testosterone. Now, we can see the different effects on germ cell damage. Like germ cell damage, effect seen when the radiation increases more than 1 to 6 gray. It presents as testicular atrophy. We can screen it by Tanner's staging, testicular size, LH, FSH, testosterone, and accordingly we have to counsel the patient. In case of Leydig cell damage that present as testicular atrophy, we can manage it by testosterone replacement. Also, in case of testosterone deficiency, we can also replace it by testosterone replacement. Now we come to kidneys. In kidneys, progressive arteriosclerosis present as degeneration and sclerosis of arterioles and secondary degeneration of dependent structures. Effects include glomerular and tubular dysfunction, nephrotic syndrome, bladder fibrosis or hypoplasia, hemorrhagic or non-hemorrhagic cystitis, ureter and urethra can also be affected, which present as recurrent UTI, for which we have to give UTI prophylaxis. For nephrotic syndrome, we consider diuretics and low salt diet. And for others also, for bladder fibrosis and hypoplasia, we need to advise exercise to the patient. And for cystitis, we have to refer them to urologist. Now, the digestive tract. Acute radiation injury and late radiation injury. Acute radiation injury occur due to depletion of normal proliferating cells, mucosal sloughing, and villus shortening. Patients suffer from odynophagia, dysphagia, abdominal pain, diarrhea, nausea, vomiting. These are the symptoms of acute radiation injury. While in case of late radiation injury that occurs due to vascular damage, mainly characterized by malabsorption, pain, bowel obstruction, perforation, infection, and death. Later effects include enteritis, for which we do stool analysis, and accordingly we have to give the dietary management to the patient. Fibrosis in esophagus presents as dysphagia. In small intestine, it presents as obstruction, while in large intestine, it presents as constipation and rectal pain. We need to do upper GI and lower GI scopy, and accordingly, for example, for esophagus, we have to do esophageal dilatation. For constipation, we have to give stool softeners and high fiber diet. Now, pancreas. Pancreas are resistant to radiation therapy. However, if there occurs any damage to islet cell, that might lead to diabetes mellitus in later stages. If we talk about liver, the radiation can cause radiation hepatitis that will lead to pain, abdomen, weight gain, ascites, increased abdominal girth, jaundice, and elevated liver enzymes. Acute radiation injury in liver present as liver becomes hyperemic and enlarged in case of acute radiation injury, while in chronic radiation injury, it gets atrophied along with sinusoidal congestion and hepatic fibrosis. Now, next organ is eye. In eye, lacrimal gland causes decreased tear production on exposure to more than 50 gray of RT. Eyelid ulceration can the second side effect is eyelid ulceration that can lead to blepharitis. We can also see telangiectasia, conjunctival necrosis, scleral thinning, corneal thinning, and keratinization, which usually present as reduced visual acuity, cataract, which need cataract surgery, iris neovascularization, retinal infarction, hemorrhage, secondary glaucoma, and optic neuropathy. Next is ear. Patient can develop decreased chronic otitis and conduction hearing loss on exposure to radiation of more than 35 gray. High frequency sensory neural hearing loss on exposure to 30 to 50 gray of radiation. Patient can develop chondritis on exposure to 50 gray of radiation, and while chondronecrosis on exposure to 60 gray of radiation. Xerostomia, that is dry mouth, is usually seen when glands are irradiated. More than 50% of glands are irradiated with more than 40 gray of radiation. Patient usually develops decreased salivary flow and dry mouth with altered taste. So, to conclude, we have seen that there is significant inter-individual variation in response to the same therapeutic exposure, reason of which is unclear. It could be because of cytotoxicity of chemotherapy received, surgical intervention, genetic makeup of the individual, length of the survival, and impact of physiological late effects on the quality of survival must be considered in therapy selection. Thank you.